thing to tell you is that what I have up here is I'm the site occupational medical director. What that means is I'm the medical director for the laboratory here on site. That site occupational medical director is actually a word that's used in the regulatory realm. We have some regulatory requirements to have medical folks on site. So what I want to tell you is that we have, you may or may not know, that we have a full-time doctor on site, that's me. We have 3 full-time nurse practitioners on site. We have 2 full-time nurses on site, 2 medical assistants. We have occupational therapy on site 2 days a week. We have an optometrist 1 day a week. There might be some people I'm forgetting in there. We are backed up by an entire environmental health and safety team, and that's probably another 100 other people who spend their time doing nothing but looking at risks, trying to figure out what it is that people do and how can we minimize those risks. I'm not going to take you through my entire bio. I think most of you have access to that if you go to the lab directory. What I want to give you is just some basic credentials and then some basic experience so that I can then walk you through what I'm going to term as sort of medical interpretation of all this raw data that's coming at you. So I am board certified in public health, occupational medicine, family medicine, and toxicology. I spend majority of my time here at the lab, but I'm split between here and the University of California, San Francisco, where I teach. And so that's sort of, okay, that's my credentials. To give you a sense of experience, the first time that I had dealt with the pandemic, it was in 2008. We were just coming off the bird flu. I was in Afghanistan at the time with the Army, and part of my role was to work on the public health on the Afghan side. And so how were we going to deal with that? Then the next time that we dealt with pandemic, I was again with the Army, I was in Kuwait, and we had something called the Middle Eastern respiratory virus, or MERS, also a coronavirus. So we were in Kuwait and had a variety of things that we were trying to deal with. It was also the first time that we had recognition that something else was going on. Syria had used sarin against their people, and so we were dealing with 2 things at that time. And the reason I point that out is that even though we were going to be talking about coronavirus today, there's a lot of things that we are multitasking, multi-managing, and your public health departments, the State Department, Department of Homeland Security, they're all looking at all that stuff. And then in 2015, we had Ebola. I was at San Francisco General then. Again, you can imagine the sort of temperature that raised collectively about how we were going to deal with Ebola and all of the plans and planning that went through. And then I guess most recently we've had the wildfires, although not an infection, another kind of planning process we went through. So I tell you that so that I can give you my perspective on how to interpret what we're seeing and to give you a chance to ask questions. Things that have changed since 2008 is nowadays you have the ability to get information to you instantaneously. This thing is talking at you, so much so that now they plug it directly into your head and you're just getting these things over and over again. One of the things that you don't get is interpretation. What does this all mean? What does 99 people with this disease mean? What does 100 mean? So that's my hope here. As the site occupational medical director, my role from a statutory standpoint is to advise the lab, to give the lab the best set of medical advice that I can give. That's not law, right? I can tell the lab, hey, this is what I think you should do. This is what the science says. This is where public health is going. The lab doesn't have to follow that, right? They can say, well, I hear you, Tamar. I hear you, Doc. This is what the science says, but we're going to go this way. So as we have this discussion today, we can talk all about that. Why are you giving that advice? Where is that coming from? And I really think it should be this other way, and we can talk about that. Before I get started, I did have one note that I wanted to talk about, which is, although we're going to talk about some of the sort of technical aspects or the way that coronavirus is rolling out, I have been reminded about how this is affecting people throughout the world. We have people here in Berkeley who have family in Wuhan, who have family in China. We have people who have sick relatives in China and can't get back to Wuhan. And so what I want to do is just recognize and take some sensitivity to understand what that means for people. It's Chinese New Year. This has changed a lot of people's lives. And so I want to make sure that we recognize that, because part of what we're getting in terms of the information is this sort of fear factor. And I don't know that that's intentional, but that's what the result is. I can tell you the number of calls that we get at health services. And so I want to recognize that that's a component as well. And so to be honest with you, the majority of what we're seeing is not anything not anything infectious related. It's the anxiety. And I hope to at least address some of that here for you and give you some resources for it. As I said, I really only have about 9 slides, and so I'll spend the majority of the time just opening it up to questions. Let's see, what did I do wrong here? All right. So most of you have seen something like this. What is the coronavirus? So coronavirus is just a family of viruses. Chances are some of us have seen one version of coronavirus in our lives or another. This particular one is what we're calling novel, new. There's something new about it. It does something a little bit different. It attacks in a different way. And it was first recognized in China in December. We're not entirely sure where it's coming from, but maybe it's thought to have come from an animal market. Maybe it's come from bats. It's worth recognizing that this information is changing as I'm talking to you. So I can't outrace you in Google, but my sense is that you will see that some of this stuff is changing. But the idea is that it is a family of viruses of what generally causes an upper respiratory illness in a variety of species, including humans. So what does it mean to us in the United States? I made these slides with the help of our communications folks, so thank you, because they're much more polished than anything I would ever do. But we've had less than 10 reported cases. That was at least as of Thursday, and I think we don't have much more. We've had a few. You've probably seen some things about, well, there's been the first human to human. We'll talk about that. That was in a couple who was living together, so really not that surprising, right? The people who we've seen are people who were recently in contact with someone who actually had the exposure, or actually had some sort of exposure. So that's an important key, is do you have the exposure? From a medical scientific standpoint, that's what we really are looking for. And we know that Homeland Security, State Department, a variety of other federal agencies are screening for this at ports of entry. So since I have you in this room, I'm going to use it as a platform to talk to you about the things that I think I'm most worried about from a health perspective and from an infectious disease perspective. And right now, that's flu. We're in the middle of peak flu season. The risk that you have right now from flu is much greater than it is from something like coronavirus. Now, again, that can change, but if I had to say there's something I'm going to worry about, I want you to get your flu shot, right? We have, as you guys probably know, we have flu campaigns here. We have flu shots. We still have them. We just finished one round, so we have them at the lab with their on back order. They should be coming in any day for those of you who want flu. You don't need 2 flu shots, by the way. I've had a question asked that. You don't need 2 flu shots. So I've got the statistics up here. I won't read them to you, but you can get a sense. I just showed you that we've had a total of 10 cases in the United States, but we have thousands of flu. So one of the questions that we get is, so what's the lab doing about this? So we are following the way that my advice has been, that I see the leadership following is we're going to follow best practices, evidence-based, what's coming out from people or agencies or that legitimately know sort of how best to handle this. And so we're halting business travel to China. Well, that's because the State Department said, that we've seen this sort of ramp up. And so now, following the advice of the State Department, we've advised, hey, maybe we should stop travel. We're working with all levels. There's a whole bunch of different public health agencies that are involved, not just in coronavirus, but in flu and a variety of things. We're monitoring, working with, talking to, and interacting with all those folks. From the city of Berkeley has its own health department, all the way up to the CDC. We don't interact with every agency, but we know they exist. Same with our DOE partners, same with our UC partners. And then we're spending time trying to educate folks. My job, if my hope is at the end of this, you come away with some education and maybe some knowledge that can help maybe combat some of the things that's causing some anxiety. But I'm not here to make things, to sugarcoat things for you or to tell you things that aren't true. I want you to know the truth, and I want you to be able to interpret that as best as I can with my education and training. So when we talk about infection prevention, all the stuff that applies to coronavirus also applies to influenza, also applies to chickenpox. You can go through and name a whole host of things that people can give one another, and some of us have had at one point in our lives. And it's the same thing, right? The big piece that we talk about is trying to make sure that you wash your hands, trying to make sure that we do all the hygienic things, all the things that you got taught in your elementary school education about trying to improve hygiene. That is what's been shown both scientifically, and that's what the different agencies are pushing, is this is what is known to reduce risk and reduce risk of exposure. So I won't read them all to you, but I think most people are familiar with these things. Staying home when you are sick is probably an important one. We have policies and procedures here that allow for that. If you're a person who needs to work from home, you can work with your supervisor and get those things kind of worked out. These are specific CDC recommendations that talk about what to do if you're sick and what to do if you are at work. So we have things like routine cleaning, having adequate supply of tissues, training others, staying home if you've got a fever. Those are all things that are adequate, that we have access to here. Someone says, I don't have tissues. Well, we have a mechanism to get you tissues, right? If you don't have those, let somebody in your department know, let your supervisor know. We have EY, we can get you those things. All these things are readily available. So this is a big question, and I suspect that we'll get a lot of questions on this. So I thought I would put this up front, and then we can talk about the specifics. But there are a lot of questions about masks. A lot of people are seeing masks. A lot of people want masks. A lot of people want masks given to them. So the evidence on masks is a bit complicated, so it's worth trying to understand what's out there, both in literature and then how that translates into what people are telling you. So what you see here is one kind of mask. It's what people will commonly call like a surgical mask. Sometimes you'll see something else that seals real tight to the face, and that's another kind of mask commonly called an N95. There is evidence that people who wear these kind of masks will decrease transmission to someone else. So if you have one of these upper respiratory infections and you're living with someone else, yeah, there's evidence that you will reduce transmission to that person that you're living with. If you are a medical professional and you are a healthcare provider and you have patients who are coming in with upper respiratory infections, there is evidence that by putting a mask on them, they will decrease transmission in the healthcare setting to other people. What there isn't evidence is if the general population is, or the general public is wearing a mask, does that decrease transmission? There's no evidence for that, and that's why you're not seeing anybody pushing for that. Now, that's different than what you're seeing on television, right? You're seeing the general population wearing masks. And there's a variety of things. There's a variety of different stakeholders that are involved, right? We have the general public. We have the people who are selling the masks. We have cultural pieces where some parts of the world people wear masks anyway. And there's just no evidence that they prevent the infection in the general public. Some of that we think has to do with, a lot of this has to do with operator, right? The operator error piece. Do you know how to put it on? Do you leave it on? If it gets dirty, do you throw it away? Do you replace it? Things like that. So that's the mask piece. We are here on site for you 7 to 4:30 every day during business hours. And so you have someone that you could talk to. Now, if you tell me that you just came back from Wuhan and you've got a fever, I would say, give me a call first before you show up. I'm not saying we won't see you, but just give me a call, right? And the reason I say that is that, we have other people in clinic, and so we can figure out ways to get you seen. Same with, now let's say you didn't go to Wuhan, but you did go to Bakersfield and then you showed up and you've got a fever, right? I'd say, give me a call. We are not the replacement for your primary care, but we can give you advice, and we're happy to do it. And it's not just on infections. If you're traveling or if you've slipped and tripped or a variety of different things, that's what we're here for. Some of the things we're not here for. I can't force anybody to go home. I can't force you to go home based on where you're from or what you look like or if I like you or if I don't like you, right? If that's something that is of concern for you, you think that person over there shouldn't be here, go talk to your HR partner. If there's really truly an infectious public health risk, we will get involved and we will involve public health with that. But I want to make it clear that there are processes and procedures, and we generally use the same processes for a variety of these. These are some resources. You guys will all have access to these slides. We just try to condense some of these slides. So if you're traveling, some resources from the CDC. If you think you may have coronavirus, some resources there. For the healthcare providers, as I said, we've got an entire building full of folks, and they generally know all this, but there's that. And the last piece I have on there is our UC Berkeley Employee Assistance Program. So we contract with UC Berkeley to provide employee assistance. And if you're not familiar with that, that's a counseling service. And I'll tell you that in the last number of pandemics, or at least I would say public health urgencies, emergencies that we've dealt with, wildfires, corona, variety of others, we have seen much more anxiety, much more what I would call psychologic impact than we have true health impacts. And so we found the employee assistance to be very helpful for that. And so I would advise you to talk with them. Now, if you have a question about viral transmission, medications, things like that, give us a call, no problem. If you're feeling stressed out about this and this is giving you a variety of anxiety, I would say call them. That's what they're here for. And it's not just for this. It can be work-related, unwork-related, things that are going on at home. Before I end, I want to point out a couple of things to you. As you guys walk out the door, and I think we will have these posted for you online, we've condensed down what we have as resources. And so you'll see this little half page on your way out. The CDC put something out that I think would be helpful, and if you guys wouldn't mind taking a few of these. If you can't read it, it says, keep calm and wash your hands, and it's got the CDC logo on it. So if you wouldn't mind taking that out to help remind people. And then this is also another CDC handout that we like that says feeling sick, and then it's got some advice of some signs to look at and some things you should think about if you think you're going to go to work with fever or things like that. So before I open up to questions, I see that we have a San Francisco fan in the room, and the reason I bring that up is if I were to gauge for you the biggest risk of what I'm concerned for the general population over this weekend is, what would you guys guess? Yeah, traffic accidents, right? No drinking and driving, trying to stay off the road. That is most likely what is going to be, if you were to look at this weekend, the biggest concern. And so I can't end a talk to a group of people without reminding them that's probably your biggest risk this weekend. So I will end there and then just start taking questions. I think we have questions online, and then we've got a mic in the room so you can see Nena who
yeah, I'll start with an online question if you don't mind.
Sure.
We have over 200 people online. And so the first question is, what caused the World Health Organization to declare a global health emergency, and what does this mean?
So what caused it? I'd have to go back and look at the specifics. I'll tell you what it means first. When you see a public health emergency that's declared either at the local level, so we've seen this in California, you'll see it like after the wildfires. The reason that that's done is it allows a variety of resources to come together. So it's not as if there was something different between Thursday and Friday or Wednesday and Thursday in terms of the number of diseases. Obviously, we were seeing more people between the 2 days. The reason that that's done is that it allows for coordination, freeing of funds. It has some reporting requirements between countries. It then invokes some international law. So it opens up a new level of playing field of what different countries have to do, what different international companies might have to do. If you operate an airline, let's say, and you like to make lots of flights between one place and another, now that there's a public health emergency that's been declared internationally, there's certain rules you have to follow. So that's what that is. It's a mechanism that allows the different countries on an international level to have the same level playing field and to be able to prepare. If you look at some of the discussion around how and why and so forth, some of the public health agencies like the WHO had gotten criticized in the past for not declaring it early enough. And if you would have done it early enough, this X, Y, and Z would have happened. There's also been cases of people saying, please don't declare a public health emergency. That we saw this with Ebola, because this is going to impact our country, our continent, things. And so it's not, as you can imagine, not purely just an epidemiologic number. Well, there's a specific number that we will declare this. There's a number of factors that go into why this is. But what it allows for is this sort of international coordination and cooperation amongst countries on this very specific topic. Any questions in the room? Okay. So there's no evidence. That's a great question. There's no evidence of quarantining asymptomatic, non-exposed people. So I should probably put this in a variety of different contexts. One is that China's got a lot of people, and it's a big place. Now, the things that so the risk factors for right now, as we understand them, for transmitting this is having an actual exposure. So just the fact that somebody's from a place or traveled from a place on its own is not sufficient, at least as we're being told today. The reason I bring that up is that there are other things. I think I had mentioned earlier, we have people who are being screened, let's say, at the airport. Now, this could change if the public health agencies then turn to us and say, you know, based on the pattern of disease we're seeing, based on the way this is being transmitted, we now think that people should be self-quarantining for 7, 14, and so forth. Then obviously we would point to that. And I would say the flip is true too. There's nothing for me to go and point to somebody and say, well, you traveled from some place that's 300 miles away from the closest point of exposure. I think you should stay home for 14 days. I have no evidence and I have no science to base that on. And so part of what I think the lab is trying to do is to be a leader in, you know, practicing what we preach. And if there is evidence for something, then I think we should implement it. But if there's not, we have a hard time pushing that. Sure. Sure. So I'll repeat the question because I'm not sure how well it picks up on the television gizmo. So the question is, what's the risk of traveling internationally? And I'm going to answer that in two ways. And I think the question was Africa. I'm going to answer that two ways. I'm going to answer it generally in terms of what does it mean for just about everything other than coronavirus, because I think it's worth thinking about that. And then I'll answer it with regards to coronavirus. The way that we do our risk assessments, there are a variety of different databases that we will look at that are updated nearly daily. And so my answer on both tends to be it depends. Depending on where you're going, there are some places that you're going to have no risk of coronavirus, but there's a lot of risk of malaria. And so if you're going to a place that's a malaria endemic area, that's the place that I'm going to worry about and I'm going to talk to you about something that we need to do, you know, X, Y, and Z for. If you tell me I'm going to this continent and we start to see that there is a uptick in coronavirus there, then we'll look at that and we will help you interpret the data. I haven't seen anything that says travel to this particular place, this particular time is at any greater risk. One of the things that I'm not very good at is predicting. And so I couldn't tell you that by today or tomorrow, this place in Africa is going to, or this place in Europe is going to be an issue. We continue to monitor that and provide the best risk estimates we have. I haven't seen anything other than I think what we're talking about now with regards to Wuhan, and as we're starting to see some of the messaging spread out to China, maybe a particular Asian country, things like that, but nothing specific to continents or continents. To follow up that, what would define the virus being contained, that it's not spreading outside of its origin? Yeah, it's a good question. So the question is, what's the definition of containment? So it depends, and part of the reason that it depends is that the what we call the epidemiologic curve. So if you were to look at a graph that started to show, well, this is when we started to see a lot of these infections, and it generally tends to be a lagging type of curve. We say, well, it got to a particular point, and then it's starting to go down. I couldn't quote for you a specific number. What happens is the public health authorities are looking at that regularly to say, this looks like this is continuing on, or you know what, this looks like it's going down. And there are a variety of different factors. There are some numbers that you'll find in a textbook. I couldn't quote them for you. But the way that that's interpreted is by looking at the way that curve is. And my sense is we're fairly early on in this. And as some of you may have had some experience with, there were some things that we thought this is gonna go on forever. And about a month in, it was all over. And otherwise, we see, well, this is going on at sort of what I call sort of a small smoldering rate. We see little cases here and there. So public health, WHO, CDC, and so forth will define that for us. But I couldn't give you a specific threshold.
One is, what illnesses are associated with this coronavirus, such as pneumonia?
Sure. Yeah. So the probably the latest paper, there's a pretty well-known medical journal called The Lancet, and they published a review of the 99 or 100 cases yesterday or the day before. And so what they had in The Lancet were the resulting effects of this, right? So you get an upper respiratory disease, which could be something as common as what you and I understand, the common cold, cough, fever, sneezing, maybe shortness of breath, all the way down to something that requires you to be in the hospital. You have an infection in a part of your lung. Your lung's really just not breathing as well as it normally would. So there'd be a breathing machine that would help you do that. Those are all the resultant pieces. If you go on and just Google The Lancet Corona, you'll see this come up. I think it's worth reading at least the introduction. Some of it gets a little technical, so I wouldn't ask you to try and interpret all of that. But you'll see there's about 100 people that were characterized there. There were no children that were in that, which I think is interesting. About 12% of the people had a version of chronic disease, had diabetes and things like that. I think it won't surprise anybody if we start to see that there's a pattern here and that there are certain groups that are at higher risk than others. They haven't been defined yet, but it's pretty common in the infectious disease epidemiologic world where we start to see certain patterns. I think we're either early or just don't have enough information to characterize that.
What are your thoughts on the possibility of asymptomatic carriers of the disease?
So there's one, yeah, it exists. It's been reported. I think it was reported in the New England Journal. There's one case of we know that it exists not just for coronavirus, it exists in general. So the idea is somebody had an exposure and didn't realize they had the exposure, and then they go on and carry it and then become symptomatic. Right now, that's being labeled as about 14 days, that there's a period of time where you could have this infection and not actually have symptoms of it. That's not a new phenomenon in medicine. That's something that we're well aware of. The idea is what do we do about it? 14 days has now become the marker of, well, maybe we'll tell people to stay home for 14 days, or we'll tell them to do something for 14 days. My sense is it's so far from the people who are looking at this that hasn't become commonplace enough that it would trigger the isolation of people who are asymptomatic. And so we know it exists. I don't think it has changed on a widespread scale. Now you will see what I would call a race. We'll call it an arms race for lack of a better term, but you'll see different organizations, generally not public health organizations, who are running to outdo one another. So one person will quarantine an asymptomatic person for 7 days. Someone decides they're going to do for 14 days. Somebody else is going to do 21 days. We are staying out of that, particularly because there's just no evidence for it. But you will see that. I wouldn't be surprised if you see somebody, an organization that says, this is our business and we are going to shut down for 14 days, or we won't allow you to come on for 14 days. We haven't gone there, and the reason we haven't gone there is we don't have any evidence to push us in that direction. I'm not saying we wouldn't do it, and I'm not saying I wouldn't advise for it, but I just don't have any evidence to push for it. Sure.
A couple of travelers
Okay.
online audience. One is going to Hawaii. Would like to know, is it advisable to wear a mask while you're on the closed quarters of the plane?
It's a good question. So the issue on masks in a plane, our mission with masks in general, going back to my original topic, was masks are only as effective as the operator who's using them. So if you think that you are going to get on the plane and you're going to wear that the entire time and you're going to maintain a seal and you're not going to get it dirty and you're not going to take it off, and if you do take it off, you're not going to breathe, then it might work. The issue is we know humans generally don't do that. And the reason we know that is that most of the evidence that looks at this looks at how masks are used in a very controlled setting. It's in a controlled setting where we're able to watch people. We're able to measure both what's outside the mask and inside the mask. And so we generally know that masks just don't work in that scenario. Now, there are other scenarios where they will work in generally in the occupational setting where we force somebody to wear a mask and they can't take it off, other than, sort of life and limb kind of thing. We know that generally tends to work. But they could wear one on the plane. The question of the effectiveness, generally, it just doesn't work for all of the things I pointed out. I would tell people, if a mask makes you feel better, okay, wear it. There's plenty of things that people do that I don't have any evidence for, but it makes you feel better. And if that's the case, I say go for it. I would also ask you that if somebody's not wearing a mask and they're otherwise not symptomatic, there's no reason for them. I don't have any reason for them to wear a mask. So I'd caution you on pointing at people and saying that person looks like they should be wearing a mask and they're not, because we know humans and we know human behavior. So there's a flip side. I think there was a question up here. No.
So one of the things, I'm not supposed to hold the microphone. That's clever. One of the things that we're told is to avoid touching your face, your eyes, your nose especially. And I wonder if masks might discourage doing that.
It's a good question. So that has been brought up. The thought that if I put a mask on, it's sort of like the cone of shame that we put on your dog. Maybe if we put it on there, they can't. The human won't touch their face. There's been no study of it. I'm glad you brought it up because I wasn't going to bring it up unless somebody did. There's some concern that the mask in the general population may actually increase risk. I don't know that there's any evidence for that. But the reason is you have this thing that's stuck over your nose and mouth, and you decide you're going to pull it off every once in a while, which is normal human behavior. But we have increased frequency of touching in and around the face. The other issue that's brought up, again, it's not something I can point to. It's just sort of what has been discussed is, if there's something to get it, once you get something on that mask, you got to throw it away, because once they become soiled, generally they're not as effective. And so the idea is, I'll give you a corollary. What happens either in an industrial setting, like in a health setting, or in a non-industrial health setting, is if someone, let's say we go in to see a patient and they've got TB, coronavirus, flu, not all at the same time, just pick one for this scenario, and they sneeze on you, something happens. As soon as you're done treating that patient, you dispose of that, you get a whole new set. Generally, we don't see that in the general public. We see that people put on their mask, go to work, go to school, do whatever they're going to do, and they have the same mask 8 hours later. So for all those reasons, there's thought, we don't think this is effective. I couldn't tell you that I think it increases your risk, but we don't think this is effective. Same would hold true in the non-healthcare setting. When we have people who are grinding or doing something that causes a whole bunch of stuff, plumes in the air, they can only wear that mask for so long. And I'm sort of generically saying mask. There's a whole bunch of different stuff out there. Some of them, we have things where you can swap out what we call a cartridge. So, some of them you have to swap out every half an hour. So for all those reasons, we know in a very controlled setting, they tend to work. Some work better than others. In the uncontrolled setting, general public, we just haven't seen it. Now, maybe we'll find they are. The limited evidence that's out there right now is that they haven't been shown to be effective. I can't recall. I don't know that we have a vaccine for SARS. I know, I'll challenge you guys to Google it and let me know. The latest that I've seen is that they're working on a vaccine, but that nobody has a timeline for when that'll be available. So that tells me I don't know that I'll be able to use a vaccine anytime soon. But I think it's worth remembering that, as far as we know, we have seen some version of coronavirus before. Yes, we're seeing, more sick people with this particular strain. But it's worth remembering that this is not much different in terms of its physical characteristics, right? It's not radioactive. It's not going to go through doors. It doesn't go through windows. It's worth understanding that there's nothing, it didn't mutate into some new superbug, right? Yeah, it might be more pathogenic. It might cause more disease, and it might cause more disease in a particular group of people. But all the same things that you have been told since grade school all still apply and all still work. Hand washing, if you can't wash your hands, some hand sanitizer, things like that. Oh, good. What did it say? Thank you. Oh, yeah, thanks.
Another question is, what about, you said don't come into work with a fever.
Mhm.
What happens if you have a really disgusting cough? Is that,
Yeah, I'm glad you emphasized that. So the reason that fever is put out is that's something that can be measured, and it can be measured in a way that everybody can understand. Cough is a little bit different. There are a variety of things. There are certain things that will cause cough that have nothing to do with infection. This question was sort of, they colored it a little bit with really disgusting. And I don't have a definition for that. And the reason is I think everybody's disgusting is a little bit different, right? And so this is a question that about the only person that can answer that is you, and maybe you with your health provider. The person who can answer that is someone who's not you. Now, there are things that we will say, I'm concerned for you. And it's not, and we don't look at just cough on its own. We know you can transmit infections with cough. But there are certain things that we look for that will make me say, well, this is really concerning. I think we need to do something. Tuberculosis is a classic example of that. But that's not just a cough, right? We go and interview somebody and say, hey, do you have all these things? Have you had this exposure? Oh, yes, I had all that. Okay, now I really think you need to not go to work and things like that. Cough or disgusting cough on its own is not something that I would bar somebody from work. But I would say, use your judgment. If you're having if you're having that kind of cough, you probably don't feel that well. So this might not be the time to come into work, and your coworkers would appreciate that. But I'll tell you what is what you see and what you see from the CDC is fever. And fever, when you haven't used any sort of fever-reducing medicines, the common ones people are familiar with are like ibuprofen, Tylenol is a brand name people are familiar with, aspirin, things like that. So 24 hours, no fever, or fever-reducing medicine. Other questions? Okay.
this person's scheduled to go to Japan for work next week,
Mm-hmm.
And they've already got a person-to-person contact apparently in Japan. So the question is, what happens if it grows, if this outbreak grows while I'm not at home? Is there something I should or could be doing?
Sure. So you saw some of that happen through the State Department with some of the State Department employees. So one of the things to think about is, okay, I'm traveling over to Japan. Right now, there's no travel advisories, but something happens such that it gets widespread in Japan. If you're there, you can come back. There's nothing that I've seen that would say that they would bar that. If you're there and you're symptomatic, there's no reason you couldn't come back, other than there's going to be a variety of things, quarantine and so forth. Or they would say, well, why don't you wait till you feel better and come back? But as of today, as we speak right now, there's nothing that would preclude them going. I think it's worth recognizing that Japan is pretty far away from China, right? And so is Korea. And so, although they're sort of in the Asian, continents, they're pretty far away from each other. And so, being able to recognize the risks are a bit different, just based on geography, is probably worth noting.
With this, they're asking yoga mats, countertops, where's it going to live and for how long? And will it then transfer to something else if it doesn't touch the yoga mat?
Sure. Some of that, so I'll give you some general answers. I'd have to look up specific for coronavirus. One of the questions that you're asking is sort of, are there things that are more likely to hold on to something that's not? And so we term that as sort of porous stuff, carpet, yoga mats, fabrics, things like that. Compare that to something like a countertop, plastic, things that it's not able to be porous. I'd have to look at the specifics around how long coronavirus lives, and that might actually be a Googleable thing, how long they live on surfaces. I haven't seen anything that has described transmission from a person to an object to another person for coronavirus. And that second object is something we call a fomite. It's just a term, it's sort of term of art that we use. I haven't seen anything that says this transfers to this, that transfers to that. And so generally, what we're concerned about is if someone was in an area where there was somebody who was symptomatic and you walk through and you walk through after they had just sneezed or coughed or things like that. So there is some period of time that they can live. It's probably worth talking about, like, what should I use? Should I use hand sanitizer? Should I use soap and water? Should I use Lysol? So from a person, for your hands, the thing that we like to tell people is soap and water. And the reason we like soap and water is because it works and it generally doesn't cause your skin to break down, right? If you don't have soap and water, then yeah, hand sanitizer is great. It's about 70% alcohol or ethanol. You only do that so many times before your hands start to bother you a bit, right? So if we can get a cycle of hand washing plus some hand sanitizer, that's great. What about the surfaces? There are a variety of different things out there that you can look at. Generally, chlorinated products will work. Not my favorite, right? Because as I told you, I come from a toxicology background, and that causes all kinds of other issues, right? So hydrogen peroxide, 3% hydrogen peroxide works. Some people like to use vinegar. I have to look and see if that's on there. And so whatever you decide to use, the important piece is not to get sick from that, right? We have people who will decide that bleach works really well and ammonia works really well. So if I put them together, it's going to work extra well, right? And so what we try and say is, just pick one, make sure you have some good ventilation, let it wipe down for the appropriate amount of time. It's usually about 2 minutes or so. Don't put your food down while, don't put some unprotected food down while that's there, because we're going to have another issue. Hopefully I answered that question. All right. I will hang out for a bit and see if we have any other questions. Thank you for coming and thank you for your questions. My hope is that this was useful for you for some of the interpretation piece. I think we're going to, we'll put this out online. You're going to see a variety of different communications around this. If I could reassure you that we do have plans and the leadership is working on plans, as you can imagine, things are changing. And so as things change, plans will change and you'll be notified and updated. All right, thanks.